Okay, thank you. First of all, I would like to say that initially, when I was asked to review this paper or comment, be discussant for this paper, I didn't know much about Swedish system or retirement or anything of that sort. So I did a little bit of homework, and indeed, I think thinking about it, the Swedish example is a very important one to learn from. It is a very important one to learn from because Sweden has one of the oldest population of all OECD member countries. The number of older people is rising rapidly. By 2030, almost 1 in 4 Swedes will be over the age of 65. There is a risk that this will generate large upward pressures on public expenditure and at the same time provoke acute labor shortage and slower economic growth. So we already can understand that there is not a simple solution to reduce those risks, and at the same time it is clear that to maintain an adequate level of social protection without increasing taxes, the employment rate of older workers will have to increase. And this is a problem that we are thinking about in Israel as well. We are not yet there. We don't have those issues yet, but we are foreseeing the future and thinking about potential issues that might come along the way that Sweden is already facing. Now, two things that I didn't know about Sweden, and I don't think were mentioned in this presentation that we need to keep in mind, is that on one hand, the social security and tax systems in Sweden are based on individual own labor income rather than family or household or anything of that sort, which increases propensity for working. If you think about it, 2 persons earning each 10,000 is better in terms of tax accountability than 1 person earning 20,000, which makes sense then for more people to actually work. Another thing to keep in mind is that with the newest reforms in the pension system, the guarantee pension, they have a part that is guaranteed and another part, as was mentioned here, the guarantee pension is adjusted against other pensions in the world and so forth, but is not reduced by wage income, capital income, occupational pension, or private pension insurance, which means, in other words, someone can work and do a lot of other things while still getting that pension. So that pension is something that is allowed to because he arrived to the age with all the other criteria, but he can continue to work, he can continue to do whatever he wants with the same employer, another employer, and that, of course, is another thing that would encourage someone to continue working. So with those two things in mind, I think it's important to look at the findings of this paper. First of all, one of the great things that I took away from the paper is that, not surprisingly, people act rationally and respond to incentives. That's always great to see. I mean, sometimes we have doubts, and in this case, it actually fits our models. In what way? First, Sweden doesn't have a generous early retirement program, so people are searching and finding alternatives. Historically, those alternatives came in the form of disability insurance, and in cases in which those eligibility criteria and requirements in order to get the disability insurance were tightened, then they switched. They switched to other type of programs. They switched to unemployment and sickness insurance or occupational insurance, and at the end of the day, they continued to find some kind of an outlet. One thing that I was initially surprised when I started reading the paper was that the paper starts with the abolishment of certain benefits, some of the benefits in the disability insurance, etc., as you just heard. And for me, it was a big surprise. I mean, someone who doesn't know the Swedish system, but one thing that I do know is that the Nordic countries are very, very generous, and the welfare system is probably the best in those countries. And we know that if there is something that we can do right, is to try to emulate whatever they are doing, because in actually, I think in all measures of life satisfaction, growth, and any other measure that you can find, you always find those 4 or 5 Nordic countries, including Sweden, there at the top. So I was, for a moment, afraid that here they are changing the rules and they will no longer be in the top. But then I realized very quickly that they are trying to trick us, because they actually didn't do that. Now, in terms of the main conclusion, so yes, the first conclusion that I found when I read the paper was that people respond to the different forms and regulations and incentives, and that goes along with my intuition. The second finding that I took away from the paper is actually the opposite of what's written here, which is that population health does affect DI utilization. And I will explain why. I'm reading the same paper by the same authors, but I get to the opposite conclusion. Basically, when you look at it, in terms of the link between health conditions and disability insurance prevalence, you find that mostly there is no strong correlation between health conditions measures and disability insurance recipiency. When you look at mortality, it goes the other way around. When you look at inpatient care, there is no relationship. So why did they get this conclusion? They got this conclusion because of one exception. There is one exception, that basically the self-reported impaired work capacity measure shows that indeed it is related to disability insurance. So what does it mean? In other words, people that self-report themselves as unable to work are also going and taking disability insurance. Now, that makes a lot of sense, but this measure doesn't represent the health of the population as far as I can tell. This measure is a little bit of an artifact, because if someone is already taking disability insurance and one of the eligibility criterion is to be impaired in terms of your work ability, when a survey comes and asks, are you impaired in terms of work ability, he will probably say yes. And that's why I tend not to believe this kind of self-reported measure. When we look at objective measures, mortality, no one can cheat that. I mean, either you're dead or you're not. Then you see that actually it doesn't fit. And when you look at inpatient care, so basically how much money was actually spent in hospitals, how much money, how many days or how many nights people spent on hospital beds, then you see that actually it doesn't work either. So I would, from the same data and the same analysis, I would conclude that actually there is no real good relationship between health and disability insurance recipients takeout, but rather that it's more the story of economic incentives. Whenever it was easier to get them, people did get them. When it was more restrictive, people switched to other programs. Now, another thing that people have to keep in mind, one has to keep in mind when thinking about self-reported measures, is now we are better aware of all the work on our ability to assess our situation, or I should say our inability to assess our own self-situation very accurately. The work of Kahneman, Tversky, and Kruger and Kahneman, etc., shows that people, even when faced with a very bad situation, very quickly get back to the same level of satisfaction, the same level of in comfort, etc. So I wouldn't take those ones as too suggestive, and try to keep the more objective measures as the one that I stick with. In terms of methodologies of the paper, I wanted to say a few words because this is my field of expertise. I would have been more convinced if the paper was, or the analysis was done relying on some kind of experimental or quasi-experimental design as opposed to solely an analysis of trends. As most of you might know, looking at trends by itself is problematic and contain serious identification concerns. When you look at different correlates that appears on time series, those can be the result of, for example, changing working procedure in healthcare systems over time. It can be due to improving diagnostics of certain diseases, so people now are more aware of different diseases that they were not before, or improving cure to certain diseases, which could reduce illness over time. It can be an artifact, as I just mentioned, with your tendency to define something as a problem that you might not have before. It can be due to changes of the demand for a certain type of labor, for example, the elderly or the disabled over time, that has nothing to do with those programs or the ability to take disability insurance. It can be a change in norms, whether it's more acceptable or less acceptable over time to take disability insurance. And it can be due to changes in economic conditions, overall economic conditions that might have changed over time, and not necessarily due to the changes in the reform or in the health conditions of people. Now, how do you overcome this problem? Typically, there are many methods, but for example, you could, instead of taking health measure as is, which might be endogenous to the outcome, you could take instead, for example, a measure like obesity, which is highly correlated with health, but on the other hand, probably not cannot be claimed that taking disability insurance would cause obesity to go higher or lower. You could instead do some kind of technical tricks, like, for example, using a panel data in which, instead of looking at the country overall, you would look at different counties and do a difference in different settings, and look at differences between counties, for example, that suffered more of an economic recession compared to other counties that suffered less of an economic recession, and then see whether or not economic factors were at play, or was it entirely about health and labor market and disability insurance. You could also use regression discontinuity kind of models, in which you would take those people that are just before the age that are eligible for the disability insurance, compare them to those who are just after the age of the disability insurance, and see whether the labor market performance of those different groups actually differ after and before the change. Now, I should say that one exception to what I'm saying is the analysis of the change in regulation. the analysis of the change in regulation was indeed done with some kind of a control group and more to the type of analysis that I'm talking about, not solely just a time series analysis. Finally, some question that I think could be answered with this kind of data and these kind of papers that were not addressed, and I think maybe it would be good to do that, is, for example, the paper report a lot of insights about male and female labor force measures separately. However, there are not any tables or any graphs that show what happened to the overall labor force participation, employment or unemployment in the population. Why would that be important? It's important if people, instead of doing individual decisions, make household decisions, and the decline in one labor force participation or the increase in one unemployment, let's say of female or male, is actually just to compensate the increase of the other gender. I already mentioned that I think it would be very interesting to see the analysis of labor force participation given an objective health status as opposed to a self-reported subjective or as opposed to mortality risk. That would be especially interesting because the paper already indicates that labor force participation goes down once mortality risk, which is a measure for expected longevity, is taken into account. And if that's the case, that's I think a very interesting and novel finding. People tend to work less when taking into account how long they will live, they tend to work less. So even if we see an increase in working years, this increase doesn't compensate for the entirety of the increase in longevity. I think that's a very important finding if it stands also other tests and not just the mortality risk. Finally, I think that I was at least remained a little bit puzzled about the different types of welfare program that took over the disability insurance, in the sense that I would have liked to see how much money, how does it translate in terms of income? Is it really, I mean, sickness insurance or occupational programs, are they enough to compensate for the disability insurance? Are they comparable or not? And that would actually be another contribution, I think. Thank you very much. It was an interesting paper. Thanks.
First of all, thank you for a very interesting picture that you gave us with a lot of very interesting details. I have a very general comment, and the very general comment is about the ability of the welfare state to continue living. At some point at the late 80s, everybody was saying that the welfare state is dead. They were taking the projections of everything, and they continued and the lines, and they said, well, it's not sustainable. And apparently society has a way to correct itself. I suspect, and I think this is something that sociologists should look into, I suspect that there was some change of norms, not just incentives, but also some change of norms, that somehow people realized that they had to work longer if they wanted the welfare state to continue on living, and that that these norms, change in norms, also allowed the political change in the clauses and all this. So people were not against this change, but they went together with this change. Well, we have to work longer, we live longer, and that's it. Okay.
Yeah, maybe.
Oh, you have one there.
Yeah. Just thank you both for your comments, and I agree with most of Claude's comments. I just defend myself on the unity of the health of the subjective health measure. I agree that it has problems, but I thought it was interesting pattern. It was not only the ability to work, impaired work capacity that was correlated with the DI utilization, but I think it was backed up also with several other both subjective health measure, impaired mobility and so on, and also some diagnosis of self-reported diagnosis. So I agree on the United problem, but it's at least some defense is that it was also backed up with other measures. The problem is that we now working with other health measure that is life expectancy. I can go back in time and look at the people at a certain point of time and look at their life expectancy. So that's another health measure that we try to use now, and also to use the ability of panel data to measure health. I think the sort of current mortality rate is problematic in the sense that it's not it's the health of the marginal person, but not the health of the marginal worker. So that's the problem. The norms thing, I fully agree. I have a paper together with Assa Lindbeck and Mats Persson on norms in the sick pay insurance, and then we look at it was a very rapid change in the late 1990s. The utilization of the sick pay insurance almost doubled in Sweden over a couple of years, and then it decreased. So between 1998 and 2004, it almost doubled, and then it went back again. And we looked at, we had tried to different measures different ways to measure local norms, and we also compared it to the spread of infectious diseases. Although I mean, infectious diseases is a very minor part of the utilization of sick pay insurance, and despite that, it had the same sort of pattern of spreading itself. So, so I agree. It's norms is a very in welfare systems is a very important and not enough studied subject.